invite Dr. Srinivas Samavedam sir to deliver his lecture on initiation of RRT in the ICU. Sir, please no introduction.
Okay, I would like to thank Dr. Mohan and the Reflect team for giving me an opportunity for this to be a part of this meeting. Next 15 minutes or so, I will answer this question, or I will try to answer this question whether we have a consensus on the initiation of RRT. Before I do that, by show of hands, how many of you are believers in early RRT? Very few. Fine. So I think we have an answer. The answer is no. So when only 3 or 4 out of this crowd has a consensus, I think we know that we should not do it. Nevertheless, we'll have a look at why we don't have a consensus or why we don't believe in early RRT. The reason why we are talking so much about RRT is that it's a very common intervention in the ICU. Respiratory failure, hemodynamic failure, and renal insufficiency are the 3 major reasons why patients end up in the ICU. And acute kidney injury requiring renal replacement is probably the most common organ failure that appears after a patient has entered the ICU for a non-renal indication. And as science advances and technology improves, more and more, as we saw in the workshop, more and more modalities are available to the point that we are now progressing to something called as advanced organ support or advanced system. Acidosis, traditionally acidosis, hyperkalemia, azotemia, and fluid overload or fluid management have been common indications for putting patients on extracorporeal therapy or support. And we did this, or we do this with the hope that early initiation will improve the outcome or improve the survival and shorten the recovery time. This is probably more a logical thinking or a hope rather than something that's backed by evidence. So let's look at where this data has come from. We also need to understand what we need consensus on, right? So we need to get consensus on 3 issues or 4 issues. One, does it have an effect on survival, beneficial effect on survival? Does our early RRT decrease the length of stay in the ICU or in the hospital? Or does it decrease the dependence on renal replacement therapy in the long term? Does it decrease your ventilator-free days? Or is it associated with lower complications? And mortality-wise, traditionally, we either look at in ICU mortality, in hospital mortality, we look at 28-day mortality, we look at 60-day mortality, and we look at 90-day mortality for ICU outcomes, to say that an intervention done when somebody was in the intensive care unit actually made a difference to him in the immediate long term as well. But the confounding issues when you search for a consensus among critically ill patients as far as renal replacement therapy is concerned is the case mix. Most of the published data has a very heterogeneous population and heterogeneous group of patients on whom the RRT has been applied. So you have trauma patients, you have post-cardiac surgery patients, you have septic patients, you have obstetric patients, and you have traumatic brain injury patients on whom different modalities of RRT has been applied when the disease severity was also very heterogeneous. All the published data have Apache scores ranging from single-digit Apaches to more than 25. So you have patients who are expected to do well, and you have patients who are not expected to do well, and the same logic applies to the SOFA scores as well. We have applied RRT to patients with lower renal SOFA scores as well as those who have higher renal SOFA scores and tried to see whether the outcomes are the same. And modality-wise, there is more confusion on this issue. Some people have studied exclusively intermittent hemodialysis. Some studies have included sustained low efficiency daily dialysis or prolonged intermittent renal replacement therapy, and some have used the continuous modalities. And there has always been a crossover. Those who are started on SLED have transitioned to CRRT, and those who are on CRRT ultimately transition on to SLED. And all this cohort is in the same mix, and then we have tried to make generalization. The duration of RRT has also been a confounding issue in these studies. So some of them have done for 6 hours, some of them have done for 8 hours, some of them have run off the filter in 24 hours, while some of them have run the filter for more than 36 hours, when you're talking about continuous renal replacement therapy. But in the last few years, if there have been few studies which have changed the paradigm in which we look at intensive care issues, like the IF, the process, the promise, and the ARISE trials have actually made us relook at the way we approach resuscitation of critically ill patients in shock. Then there is a tetrad of studies as far as renal replacement therapy is concerned, which probably have provoked us to relook at the way we look at the timing of renal replacement therapy in critically ill patients. The two Akiki studies and the ideal ICU study. So we'll look at those studies in a little bit of detail. So this is the first of those four studies, the ELINE trial, which is probably the only positive trial which argued in favor of early renal replacement therapy. This was a single prospective randomized controlled trial from Germany, which randomized about 230 plus patients, 110 or 112 in each arm, and tried to put them into early renal replacement therapy, which is less than 8 hours after identification of the rifle criteria for renal replacement, or more than 12 hours using the same criteria and put them onto renal replacement therapy, and found good results in terms of mortality, in terms of the timing of time on RRT, the renal function, and hospital stay. But this was a smaller study. This was a single center study, unblinded study, and a lot of heterogeneity in the inclusion of these patients, and the results of this study would not be replicated in subsequent studies. So if you want early renal replacement therapy in a patient with AKI, so maybe you should put them on a flight to Germany and send them to this particular ICU, then it will be a good outcome for your patient. That's the inference I can get from the ELINE study. We will look at the pros and cons of these four studies after we discuss the other three as well. But this was the only positive study in the last 4 years which has argued in favor of an early aggressive renal replacement therapy. Then the sequence of French trials came into the picture. The first of the Akiki studies, which is a multi-center prospective unblinded study from 31 French ICUs, which randomized about 620 patients, half of them into each of those arms, where they initiated RRT within 6 hours in the early group, and they delayed it for more than 48 hours in the delayed group, and found absolutely no difference in terms of mortality in the ICU or in hospital, and no difference in the modality, ultimately the modality of RRT, the number of days the patient stayed of RRT, or on mechanical ventilation, or number of vasopressors. So early initiation of RRT did not give any benefit in improving the hemodynamic status or the pulmonary status of patients, while also not conferring any benefit in terms of renal recovery or their dependence on renal replacement therapy. So this was the first one which raised a flag against the early initiation of renal replacement therapy in patients whose Apache score was more than 50. The ideal ICU trial was a very similar study, again done in 29 French ICUs, randomizing about 500 patients into early and late, where the timeline for initiation was extended from 8 hours from the previous study to 12 hours, and the advanced or the delayed RRT initiation happening at the end after 48 hours. Again, when you looked at the mortality, the need for renal replacement therapy, the RRT free days, the mechanical ventilation days, and the vasopressor days, there was absolutely no difference in the both the subgroup. And this is one study where the septic shock cohort was the predominant case mix. The previous ones included trauma, included cardiac patients, septic post-operative patients, but the ideal ICU study is the one which had a higher percentage of patients with septic shock and found absolutely no benefit in terms of the core outcomes when you look at early versus delayed. The final one, which probably tilted the balance, and when you look at the randomized controlled trials and put them into meta-analysis, this is the one which swings most of the meta-analysis in favor of delayed initiation of RRT, that is START AKI study, which is again a multinational open label RCT looking at in 15 countries across 168 hospitals, and randomizing or including about 3,000 plus patients, finding absolutely no difference with the standard therapy compared to accelerated strategy, where renal replacement therapy is initiated within 12 hours after the diagnosis of AKI as per the Kidigo criteria, and found absolutely no difference. In fact, this study identified a higher rate of complications in patients in whom an early aggressive strategy for the initiation of RRT was the norm for support. So when you compare these studies, the Elaine, the Akiki, the Ideal ICU, and the START AKI study, we know that they all randomized patients in Kidigo stage 2 or stage 3. And they also, only the Ideal ICU looked at the rifle F and then initiated those patients and randomized those patients. So the main problem, as I said, for the Elaine study was that the results were potentially skewed because many of the early patients may have recovered without renal replacement therapy, so that probably skewed the data. The Akiki had a limited generalizability because there was a mix of intermittent hemodialysis and continuous renal replacement therapy. The Ideal ICU study has a drawback that there were inconsistencies between the Kidigo and the rifle AKI criteria, so there was again a heterogeneity in the case mix which was randomized. And the START AKI study has again had heterogeneity because the time to initiation varied between 6 to 12 hours and not exactly the 12-hour gap or 12-hour cutoff which the authors had set out. Despite all this, except the Elaine study, all the other 3 studies have demonstrated no additional benefit with the early aggressive initiation of renal replacement therapy among critically ill patients with Kidigo 2 and 3 stages of acute kidney injury. Needless to say, when you have such a big number of randomized controlled trials coming in close succession, a series of meta-analysis will follow. When you have a big study, like you have 3 studies which have 200, 300, 400 patients, and then one author comes up or a group comes up with 3,000 patients, definitely somebody will be motivated to do a meta-analysis to see what happens, and that's what happened. There were 4 meta-analyses and a 5th one as well, which I will quote, which were published in the last year. In this year and immediate preceding year, which have looked in the Nephron, in Journal of Intensive Care Society, in Critical Care, and also in the JAMA. So they looked at early versus late initiation of renal replacement therapy and putting the major studies. They have included all the 4 which we have done and one by Bagshaw et al. Preceding these 4 and try to put those case mix and come to a conclusion. So if you look at our first point of consensus, whether it makes a difference to overall mortality, the meta-analysis have shown equivalence. That means early initiation of renal replacement therapy is probably equivalent to a delayed initiation of renal replacement therapy. And if you look at all-cause mortality across subgroups, only the surgical patients in whom you initiate early may have an advantage, but all other subgroups of patients probably will do the same whether you initiate the RRT early or late. Moreover, if you initiate RRT in somebody who has an AKI with a preserved urine output, the chances of that patient having a renal recovery are probably delayed according to the meta-analysis. So that was about the all-cause mortality. So whether in hospital or in ICU and according from all causes. If you look at ICU mortality and you look at all the studies which we have discussed so far, you will find that there is absolutely no difference. All the studies are centered on the median. So without exception, the evidence from all the published data included in meta-analysis seem to suggest that early initiation of RRT does not influence ICU mortality, does not confer a benefit on ICU mortality. So same thing applies to your 28-day mortality and the same thing applies to your 90-day mortality. No deviation from median, whether you look at early or late initiation of RRT. Does it decrease the length of hospital stay? Now that's a question you can answer from both sides of the divide. If I initiate early RRT, it's likely that hospital stay will prolong. And if I initiate early, does it get my patient better quickly? The answer is no. But those who are in favor of early RRT will argue that my patient did stay longer in the ICU, so it did not cause any harm to the ICU, but to the patient. But yes, while it did not do any harm, the purpose of your initiating somebody on an intervention, an invasive intervention, is to shorten or give some benefit. We have shown that it's not shown a benefit in mortality. It has also not shown a benefit in hospital length of stay. So when you look at early initiation of RRT, favorable results tended to be in those in whom the RRT was initiated later. The earlier you initiate the patients on RRT, the higher the chances of those patients requiring vasopressor support across the several studies which were published in the last 5 years. The infection rates were not very different, but tended to be a little higher in those patients in whom you have initiated the RRT early. So, if you candidate somebody who is hypothermic, acidotic, and hypotensive, it is likely that you will end up subjecting those patients or making them more susceptible to infections. Arrhythmias also did not differ between the early and late. There are again proponents and opponents of this hypothesis. A patient who is acidotic, who is probably hyperkalemic, is more prone for arrhythmias, and that is the logic which intensivists use to initiate RRT very early, and that has not stood the test of a meta-analysis. It did not prove that if you do that, your chances of arrhythmias are lesser if you initiate RRT earlier than if you initiate later. Bleeding events, no difference between the two groups. And dialysis dependence, this is where we should look at the ultimate outcome. At end of day 90, if you remember the fact that acute kidney injury is actually a risk factor for CKD in future. If you look at dialysis dependence on day 90, lesser number of patients who had a delayed initiation of RRT were dependent on dialysis when compared to patients who had an earlier initiation of dialysis. So, initiation of dialysis beyond 48 hours after satisfying KDIGO 2 and 3 criteria is not something which will make them more dependent on dialysis. It's in fact an early initiation of dialysis or RRT which will make them dependent on RRT on day 90. So that's a point we need to consider. And more patients on whom dialysis was initiated after 48 hours actually came off dialysis across subgroups of surgery, diabetic, and those who are non-allouric and septic patients. Even septic patients tended to come off renal replacement therapy quicker if the renal replacement therapy was offered in a conservative way rather than an aggressive way. So ultimately, I would conclude by answering these questions. Do we have a consensus? Does our early RRT improve immediate survival? Answer is no. Does early RRT improve hospital survival? The answer is no. Does it improve long-term survival? The answer is no. And does it help quicker renal recovery? The answer is no. And does it shorten the length of stay? The answer is no. And does early RRT decrease complication rates? The answer is probably no. But all the studies which we have described, heterogeneity in population selection has been a problem, and that's where intensive care comes in. And we don't select patients; the patients select us. So they end up in the intensive care unit with varying degrees of shock, with varying Apache scores, and you have access to varied modalities for various reasons. So you can't pick and choose your modality and your patient. So that's a heterogeneity is the name of intensive care. So we need to look at it. So mixed severity levels is also an issue. So if somebody wants to actually evaluate early versus late RRT, it should be in the high Apache score patients using only CRRT with a fixed dose of dialysis for a fixed duration with a fixed regimentation of anticoagulation. And that study will take probably a decade to recruit enough number of patients to give the statistical power for us to say that 10% of my patients did better with early aggressive RRT. Now that's something which is going to be impossible given the financial and logistic requirements of continuous renal replacement therapy in this country. CRRT as the primary modality is the issue. Some of the studies use CRRT as the primary modality, but 70% of our patients who are actually eligible for regional CRRT will not get CRRT. They will get SLED because machines are not available and it's simply not affordable for a big number of our patients. And once I say late initiation is good, how late is too late? Nobody knows. I have said 48 hours. Why not 72 hours? Why not 96 hours? Is it too late? Will I kill somebody with my attitude of not doing dialysis with an obstinate view that this does not improve? That question has never been answered. You have in the early group comparisons between 8 hours, 6 hours and 12 hours, but in the late group, nobody has done 48, 72, 96 hours. So that's all, where is the hard and fast rule that after 48 hours things will get better in a septic patient? Our patients on vasopressors have been on vasopressors for 4 days. So does it stop by the clock? It doesn't. So these are still questions which need to be answered. till such time that a well-designed, elegant, randomized controlled trial answers this question. We do not have a consensus on most things, but the consensus is do not be in a hurry to initiate RRT on your patient who is on vasopressor support with the idea that it will save him, it will keep him in the hospital for a shorter time, it will get him off the machine in a quicker time, and he will leave the hospital without dialysis in 90 days. If your thinking is in that direction, we do not have a consensus as of now. Thank you very much.
Thank you, sir. It's a wonderful presentation as usual. So, the crux of your presentation is the no role of early RRT. It will not change the mortality, it will not change the outcome. So, when it is the ideal time for RRT? So, anyway, we'll take the questions of this. What is the, you said early RRT, there is no role. And when it is the ideal time for the RRT?
I will answer it at the end of
Yes, sir. Thank you.
Outside, I would like to thank Dr. Mohan Maharashtra for inviting me to talk in Reflect 2021. The topic of what I have been asked to talk is indirect calorimetry, and is it the gold standard in intensive care? We know that nutrition is very important for all critically ill patients, because if you don't